Good afternoon, everybody. May I kindly ask you to take your seats? We have a tight program today for this session. Okay, so we'll start. Please try to get a seat as soon as possible. Hello, everybody, dear colleagues. My name is Ulrich Jäger from the Medical University of Vienna. And I'm glad to announce this symposium, which will bring together the best of two worlds, which is myeloma and lymphoma at the same time. We don't have that very often. And I mean that in terms of the fields, of the treatments, and of course of our experts who are at the table. This is a roundtable hosted by the Lymphoma Hub and the Multiple Myeloma Hub, and we called it the ins and outs of CAR T cells in the real world. I have some disclosures to make. So this is our faculty, renowned speakers in their fields. Shash Kumar from the Mayo Clinic in Rochester, Minnesota, Kieran Dunleavy, George Washington University's Cancer Center in Washington, Doris Hansen, she will be online from the Moffitt Cancer Center in Tampa, and Michael Hudecek from the University Hospital Würzburg in Würzburg. This is our agenda. We will start off with Dr. Kumar and Dr. Dunleavy, who will discuss biomarkers and patient eligibility for CAR T-cell therapies in multiple myeloma and DLBCL. Then we'll have real-world patient cases from Doris Hansen and myself. And then we go and look into the future with Michael Hudecek, answer to common challenges. And after this symposium, you should be able to understand the rationale for selecting CAR T-cell-based therapies based on disease and patient-related factors. You should be able to evaluate the adverse event profiles of CAR T-cell therapies and describe their management, discuss critical factors that inform treatment decisions, explain the real-world challenges of CAR T-cell therapy, including access, patient referral, infusion success rates, and logistics, and identify novel strategies that mitigate the challenges currently faced during and after CAR T-cell infusion. May I kindly ask you to turn off, set your mobile devices to silent. Use the QR code to access the Q&A function with your phones. We will also have microphones because there will be the possibility to ask specific questions to the specific speakers just right after the presentations. And please interact with us with the polling questions and for the evaluation feedback. We have EBA accreditation for this event. And I'll start off with the first question as a warm-up. We would like to have a bit of your profile. Have you treated a patient with CAR T-cells outside of a clinical trial, be it myeloma, be it lymphoma? Please use your cell phones and answer with a yes or no. I will start the voting. And while you do that, I have to say that we will now, in the following, ask a set of questions related to CAR T-cells that we will ask after the symposium again, and we are interested to see how you responded. Okay, that looks like a pretty reasonable profile. Half of our colleagues have treated CAR T-cells in the real world, and the other half has not. Now, we move to the specific questions. So question 1, which of the following disease characteristics is associated with an increased efficacy of CAR T-cells in high-grade B-cell lymphoma? A low metabolic tumor volume, 1, downregulation of interferon gamma, p53-mediated tumor-induced immune privilege, or p53-mediated inhibition of extrinsic apoptosis. I'll I'll start the voting. This is a bit more difficult than the yes and no question in the beginning. Okay, so most of you think that tumor volume is important when we treat patients. I guess that's a reasonable guess. And now we go on to the next question. Question 2, which of the following statements is false regarding the use of commercially available CAR T-cell therapies to treat patients with MM or DLBCL? Patients with relapsed refractory myeloma who have received prior BCMA-directed therapy show a reduced overall response rate to ide-cel compared with those who have not. A significant proportion of patients who would be ineligible to participate in the pivotal CAR T clinical trials can benefit from these therapies. Patients with DLBCL and secondary CNS relapse do not respond to CAR T-cell therapy, and due to access and production challenges, only 30 to 40% of patients with DLBCL receive the approved CAR T-cell product that they are eligible for. The false answer, false question is asked for here. I start the voting. You see that this is an educational activity, so we ask questions before and after. Yeah, so most of you think that secondary CNS relapse is still a good target for CAR T-cells. Again, seems very reasonable. And we go to the final question. Long text, 75-year-old woman with relapsed refractory multiple myeloma presents with steadily progressing disease after fourth-line therapy. She has received 2 proteasome inhibitors, 2 immunomodulatory drugs, and 1 anti-CD38. She is also being treated for hypertension and diabetes, but her general performance is favorable for continued treatment. In an ideal scenario where all approved products are available, what would you choose as the following line of therapy after 4 lines? A selinexor-based combination, belantamab mafodotin, idecabtagene vicluzal or ciltacabtagene autoleucel, or teclistamab. You have the choice, probably like in the real world. Start the voting. Yeah, interesting. So most of you would give a CAR T-cell product at this time. Good, we'll come back to that after our talks. I close the voting. And with that, I'm done with my introduction.